All right. Thank you, Chelsea. Thank you, everyone. This has been a great month for the sub-Is. We have uh, more who just started yesterday, who I'll take a moment to introduce to everybody next week. Um, we're going to move on to our next speaker. So we have well known to everybody, Dr. Shoirah, who completed in his initial training in Cairo, Egypt, before coming to the United States and completing his internal medicine internship at University of Medical College of Wisconsin, followed by neurology residency here, vascular neurology fellowship in Pittsburgh, and neuroendovascular surgery fellowship here at Mount Sinai. He has taken the lead in developing the neuroendovascular service at Elmhurst, which is now thriving, and has done quite a bit of research on stroke and aneurysm intervention. And in addition, if Facebook is correct, I believe today is his 40th birthday. So let's, if I'm not wrong, Hazem, I'll wish you a happy birthday.
Thank
Looking
you.
forward to your talk.
Thank you. Yep, happy to be celebrating my birthday, giving this talk. Good morning, everybody. This is a talk that I would consider a sequel to a talk that I gave maybe 4 years ago about the use of Cangrelor. Some of you may know my personal interest in the use of this medication. Last time we explored the general use of Cangrelor in neurointerventions, and that was in our early Sinai experience. And today, I think we're going to focus more on its use in the stroke interventions, as well as give an update from the field and from our Sinai experience as well. I have no financial disclosures. Quick background here, just to put things in perspective. Here's a real case of a 64-year-old male who had a functional status at baseline that was independent, modified Rankin score of 0, just has diabetes, and had an acute onset of right gaze deviation, left hemiplegia while talking with a friend, a very severe stroke scale of NIH of 17. He quickly got a CAT scan that did not show hemorrhage. His Alberta stroke program score was 9, aspects was 9. He did receive TPA. His CTA revealed what we see here on the left side panel. You can see that he has a cervical ICA occlusion shortly after the origin of the ICA, but then in addition to that, he has what we would call a tandem occlusion of the MCA in the M1 segment on the right side. So he was taken for a quick intervention. On the left side, you can see the run that shows the common carotid artery with what we saw in the CTA, the ICA being occluded shortly after the origin, and then the head run of the same angiogram or the same injection can show that there's complete lack of visualization of intracranial circulation on that side. We know from the CTA that that side was filling from the contralateral side with that M1 occlusion, but it can't be seen here because the injection is from the right side. He had a rapid intervention with a cervical ICA stent that was placed, as well as a thrombectomy of the M1 occlusion that was there, achieving excellent recanalization. Because he was stented, integralin was started in the angio suite. Shortly after that, he was noted to have worsening of his neurological exam and was taken for a CT that showed this pattern of hemorrhage here, which would be considered a PH2 hemorrhage in the ECAS classification. Unfortunately, he had to undergo a hemicraniectomy on postoperative day 1 and expired on postoperative day 3. Very sad case in spite of successful revascularization, but unfortunately, this is not a unique or isolated case. So to give a little bit of a background about the use of intravenous antithrombotics in acute stroke interventions, we should know that the need for emergent stenting in acute stroke happens in a couple of common encounters and findings that we occasionally find. One is tandem occlusions, an occlusion of a cervical and intracranial vessel, which may occur in 20% of patients who have acute ischemic stroke of the anterior circulation who receive TPA. We know that tandem occlusions in general have a worse functional recovery expectation and prognosis compared to patients who have run-of-the-mill stroke. We know that the chances of functional independence in 90 days in patients with tandem occlusion is less than half of that of patients with isolated intracranial occlusion, 18% versus 47% or more. In addition, symptomatic ICH may occur in a large percentage of those patients with tandem occlusion, up to 22%, and mortality could be just as high. The other situation that we occasionally encounter in endovascular interventions is when patients have intracranial atherosclerotic disease, which may underlie LVOs in almost 20% of endovascular thrombectomy cases. And when that is the case, it is associated with lower recanalization rates, higher chances of reocclusion, and overall worse outcomes. Why do we see such high morbidity and mortality in patients who have tandem occlusion? Those patients have quick progressions of their ischemia. They sometimes do require thrombolytics. The use of intraoperative antithrombotics is laden with problems, as well as the use of stents when that is necessary could also lead to thromboembolic complications. So generally speaking, in addition to the emergent need of the use of intravenous antithrombotics during our cases, there is the emergent need that can happen when patients are undergoing stroke treatment, either because they require cervical stenting, either because of atheromatous disease that could be encountered, or dissections, or if they need intracranial stenting for ICAD dissections or after iatrogenic injuries. In addition to that, there's another genre of indications of use, which is more for elective cases. For example, when we're doing adjuvant treatment of stent-assisted coiling or fluid diversion. But what the focus on the talk today is really for the emergent use of intravenous antithrombotics, mostly in the stroke intervention world. Now, what are some of the limitations that those patients encounter? First of all, these are emergent cases. Patients may not be premedicated or may not be known to be premedicated with aspirin or Plavix or other antithrombotics. So the providers would have to work blindly and kind of assume that the patient is not premedicated and treat them accordingly. Patients are oftentimes unable to swallow safely, so we can't rely on oral antithrombotics. The emergent nature of stenting in these cases, which really could happen within less than an hour, sometimes even shorter than that from arrival to the hospital, require that we use medications that have very quick time to onset. So this is kind of a schematic that shows us the different classes of antithrombotic medications. Largely speaking, or kind of the bigger picture here is that those medications can be classified into either activation inhibitors, adhesion inhibitors, or aggregation inhibitors. Out of those, the ones that are clinically used in our world are the ones highlighted in the red boxes. The P2Y12 receptor antagonists are things like clopidogrel, Plavix, Prasugrel, Cangrelor, Cangrelor, and clopidine. There's the cyclooxygenase inhibitors like aspirin, and then finally there's the glycoprotein 2B3A inhibitors like efiximab, which is ReoPro, eftifitabide, which is integralin, and tiotroban, which is more used in the cardiac literature. So here's a quick comparison between the antithrombotic classes that are most commonly used in our interventions, comparing their mechanism of action, their onset, their half-life, and their reversibility, as well as the availability in an intravenous format. You can see here that if we focus on the ones that are available in intravenous format, because when patients are undergoing endovascular interventions in the stroke world, we can't really rely on oral preparations. We can focus on Cangrelor, ReoPro, and integralin. All three of them are available in an intravenous form. All are relatively rapidly able to deactivate platelets. Cangrelor is probably the fastest because its onset is within 2 minutes, where then ReoPro and integralin are within 10 and 15 minutes. The half-life of Cangrelor is the shortest out of the three, again, 2.5 to 3.5 minutes, as opposed to 10 minutes in ReoPro or 2.5 hours in integralin, which is important because when you think that those patients have the potential of encountering complications like hemorrhagic conversion, you want a medication with a shorter half-life. Also, the reversibility is something to take into consideration. So Cangrelor specifically is relatively novel. I mean, it's been around now for a decade in the cardiac literature, less so, about 40 years or so, we started using it in neurointerventions. It blocks ADP-induced platelet activation and aggregation by the use of P2Y12 receptors. This is the way that it is supplied and dosed. It comes in 50 milligram vials that can be reconstituted, bolused in 30 microgram per kilogram bolus, and then infused afterwards with 4 microgram per kilogram per minute as an infusion or continuous infusion. Now, this regimen has been adjusted in some other centers, which we will come to in a future slide. But this is a schematic from the manufacturer's website that kind of shows the rapid, you can see the purple line here is the degree of platelet inhibition, and the green line is the plasma concentration of Cangrelor. You can see that it has a very rapid onset in which platelet inhibition reaches really undetected, its most therapeutic level within 2 minutes, and quickly restores after Cangrelor is discontinued. The leading trials for our understanding of Cangrelor comes from the cardiac literature with Champion PCI in 2009, followed by Champion Platform and Phoenix shortly after. All in all, there has been a pooled analysis of about 12,000 patients that showed that Cangrelor was safe and effective compared with patients who did not receive Cangrelor as an adjuvant therapy. In a primary efficacy endpoint of mortality, MI, and stent thrombosis, there was no difference between the use of Cangrelor as an intravenous agent and the use of the traditional setup of pre-medication with high-dose antithrombotics with adjuvant integralin, with a lower risk of major or minor bleeding in the Cangrelor arm as well. So in neurointerventions, the advantages of using Cangrelor is that it's available in an intravenous formulation. It has this rapid onset, it's reversible, and it has this short elimination life time as well as it's FDA approved for PCI. The disadvantages, which are not trivial, are that it has a high cost, about $9,000 per vial, and each patient requires at least one vial, so at least $9,000 compared to maybe $1,000 or $2,000 in some of the other medications. I mentioned the standard dose, but some other centers have started experimenting with half doses, which would bolus with 15 microgram per kilogram and an infusion of 2 microgram per kilogram per minute, or even there's some experience, as we will see in a later slide, with even smaller boluses with adjustment of the infusion rate based on the PRU of the patient. Bridging is a different technique or strategy for using Cangrelor, in which patients, not in the immediate post-stenting period, but if they had a stent placed in the last 2 weeks or 2 months, and they have to undergo surgery, open surgery for any other reason, they could be bridged off of their antiplatelet medication so that they can have effective antiplatelet medications in their system up to the date of surgery, rather than stopping the antiplatelet a few days before surgery, which is the common practice. When we talk about Cangrelor, obviously this is not a medication that patients will be on for a long time, and so we have to think of the transition agents. What are they going to be transitioning to after we stop the Cangrelor? All of those patients will be on aspirin, but in addition to the aspirin, the second agent, which would be considered the transition agent in our world, could be either Plavix, Efient, or Brilinta. Those are the 3 common medications that we use. And the transition instructions or the doses are right there. The problem here, or the thing to keep in mind, is that Plavix or clopidogrel and Cangrelor both have competitive inhibition of the same receptor, the P2Y12 receptor, whereas in Brilinta and Efient do not have that competitive nature with Cangrelor. So if you overlap the use of Cangrelor with the loading of Plavix, this essentially inactivates or kind of ameliorates the activation of Plavix, and the patient will not have effective antithrombotic effect after the cessation of Cangrelor. So in other words, you cannot overlap Plavix with Cangrelor, whereas then you can do that with Brilinta and Efient. With Cangrelor, the instruction is that with Plavix, the instruction is that as you stop the Cangrelor, you immediately at the same time load with Plavix without overlap, which, if we go back to this chart here, means that there will be the time of onset of Plavix is 4 to 6 hours, and within an hour there will be essentially no residual Cangrelor present in the patient's body. So you essentially have 3 to 5 hours of relative platelet reactivation, during which thrombotic complications may happen. So that is something to keep in mind, and you will see that in our Sinai experience, we definitely have learned from that important pharmacodynamic property. Now, in the last few years, we've had paper after paper from different groups that describe the different center experiences with the use of Cangrelor in neurointerventions. Starting from 2018, we see an experience of 8 patients. 2019, 7 patients, with only 1 patient having symptomatic ICH. 2020, 42 patients, 3 patients with symptomatic ICH. Almost half the patients have favorable outcome. In 2021, Al-Horani described 12 patients with stroke, mostly with intracranial stenting, with no thrombotic complication and 1 symptomatic ICH. Salahuddin, no symptomatic ICH in 12 patients. And then kind of more importantly, some pooled analysis of 129 stroke patients that showed, consistent with the previous experiences, a symptomatic ICH rate of 6.2% and only 1 case of thromboembolic complication with no intra-procedural stent occlusion. And then last year, Marnat et al. Published their data with a French stroke registry that had 44 stroke patients, again with a symptomatic ICH of 9.5%. Some of the limitations in those papers is that not every paper describes their dosing regimen. So there's some kind of blind spots in the field about that, as well as inconsistency in the methods of assessment of stent patency. Not all of those papers describe stent patency at 24 hours, for instance. A lot of them describe stent patency at the end of the procedure, but stent patency at 24 hours is not well described. So if we compare Cangrelor with the previously and currently used glycoprotein 2B3A inhibitors like integralin, we can see that there are some key clinical and pharmacological differences there, in addition to the times of actions that we talked about. Cangrelor does not have thrombolytic properties, whereas integralin does have thrombolytic properties. In addition, integralin is a stronger agent in terms of prevention of platelet aggregation. So in one sense, this may be potentially safer in acute stroke setting where you do not want to have excessive thrombolytic properties, which may increase the rate of ICH. But on the other hand, this may not be helpful. The use of Cangrelor may not be beneficial in cases where thrombosis has already started. You can see thrombosis in the vessel or in the stent. Platelet aggregation has already started. Cangrelor is not the best at that. In these situations, integralin may be a better choice. The other thing, of course, is the cost. As I mentioned earlier, the cost of a single vial of Cangrelor is about $9,000, whereas in the cost of a similar treatment with integralin may be about $1,000 to $1,500. So how about our Sinai experience? We started really taking an interest in Cangrelor as early as 2018, collaborated with pharmacy, approved by our PNT in December of 2018 to be used in the neurointerventional suite. And that was at MSH, MSQ in 2019. We did our first case in January of 2019 and later had even approval in Elmhurst Hospital for the use of Cangrelor, and subsequent to that, MSW and MSBI as well. So currently it is used system-wide. In the last few years, we've used it quite a bit of time. And so with collaborating with one of our visiting students, Alex, we put together a study to evaluate the use of integralin versus Cangrelor in patients undergoing stroke interventions. So we looked at all patients who underwent endovascular stroke intervention in the Sinai healthcare system between December 2018 and March 2023, in whom intravenous antiplatelets were used. Specifically, Cangrelor versus integralin were the two main groups there. RioPro is really a medication we have been using in recent years, so there was no patients who underwent RioPro treatment. We collected information about the baseline demographics, presentation, occlusion location, types of intervention, as well as their outcomes. In the outcome world, we looked at the hemorrhagic transformation rate, including their ECAS classification, and we further classified that into symptomatic versus asymptomatic ICH. The ECAS classification system is an important classification system in describing our patterns of hemorrhagic conversion after stroke interventions or after stroke, with hemorrhagic infarction and peritoneal hematoma being the two main categories, each having two subcategories. We call an ICH symptomatic if it belongs to the PH2, peritoneal hematoma type 2 category, in addition to having an NIH gain of 4 points or above, that could not be explained by other reasons. So we have a relatively strict definition of what a symptomatic ICH would be. We also compared thrombotic complications, including stent occlusion, in-hospital mortality, NIH at 24 hours, length of stay in the ICU, as well as dichotomized MRS at discharge in 90 days, which is really the holy grail of stroke intervention, is the look at dichotomized MRS at 90 days. Dichotomized MRS essentially is a way of assessing patient's functional independence with an MRS score of 0 to 2, signifying functional independence, which is really what we are seeking with our stroke patients. We used univariate and multivariate analysis and used the adjusted odds ratio for logistical regression, and the beta values for linear regressions, and controlled for many of the baseline demographics as well as the baseline variable. In that period, we performed over 1,000 stroke interventions, out of which about 140 received intravenous antithrombotics, 36 in the Cangrelor arm and about 104 in the integralin arm. This here shows our baseline demographic comparison between the two arms. Really, there was no difference, statistically significant difference between the two groups in any of the baseline demographics. Be that the age, the sex, the MRS, prior use of medications or other comorbidities. In terms of clinical and radiographic presentation, again, patients were quite well matched between the two groups. NIH at presentation was 12.5 versus 14. High NIHs, which is expected in patients who have a need for intravenous antithrombotics. Those are mostly patients with either tandem occlusion or intracranial atherosclerotic disease. Their baseline aspects was comparable, 9. So both groups had good favorable CAT scans before the intervention. Both had also equal percentage of the use of IV thrombolysis, like tenecteplase or TPA, 30% versus 26%, which is not significant. And again, the presence of the occlusion in the anterior circulation was similar between the two groups, as well as the indication being tandem occlusion. As a reminder here, the other indications are ICAD or for primary vessel recanalization. So the indication for administration here, we can see in the Cangrelor arm, mostly it was either for the placement of an intracranial stent or an extracranial stent. There were 2 cases in which it was used as a recanalization aid in vessels that were not stented but were acutely thrombotic. But as we saw in an earlier slide, this really is not the best use for Cangrelor because it doesn't have those thrombolytic properties. So that's not one of the common uses for Cangrelor. For integralin, we still used it a lot for stenting cases, but you can see that a large proportion of patients received it as a recanalization aid, as a primary recanalization aid. In terms of the transition agents that we use, we can see here that ticagrelor and clopidogrel were the 2 most commonly used agents. You can see in the integralin group, there was a higher percentage of patients who did not need any transition agents. Those are the patients who, in which integralin was used as a recanalization aid without the actual presence of a stent. So in terms of outcome, very notable here is that the overall rate of hemorrhagic transformation was significantly lower in the Cangrelor group compared with the integralin group. And that you can see here the breakdown between different ECAS classification classes there, in which in all of them really you can see that Cangrelor had less number of patients, less percentage of patients. In this unadjusted comparison, there was no difference in the symptomatic ICH rate, at least statistically significant difference. And no difference in the rate of thrombotic reocclusion, in spite of having a trend for a higher rate of reocclusion in the integralin group. Now, here a caveat is that we did not have information about the stent status in 100% of our patients, because not all patients got immediate 24-hour vascular imaging, but we do as much as we can. You can see here in this group of 140 patients, only about 90 patients had stent-free imaging within 24 hours. The 24-hour NIH was significantly lower in the Cangrelor group, 7 versus 12, and that was significant, as well as the discharge NIH, 3 versus 9. Both groups spent the same number of days in the ICU, And both groups had similar in-hospital mortality with a trend in the integralin to be a little bit more. The MRS at discharge and 90-day follow-up was significantly more favorable in the Cangrelor group. Again, MRS of 0 to 2 means that they are functionally independent. So the percentage of patients that are functionally independent in the Cangrelor group was 44% at discharge compared to 25% in the integralin group. And the 90-day was 58% versus 30%. Now, this is all in the unadjusted model. When controlling for age, gender, comorbidities, prior use of antiplatelets, occlusion location, thrombolytic use, MRS, NIH, and aspects, we can see that the symptomatic ICH rate becomes statistically significant with better odds with the Cangrelor compared to the integralin group, with a significant p-value there, as well as the same findings that were significant in the previous table continue to be significant here: 24-hour NIH discharge, NIH, and MRS at discharge, and 90-day follow-up. So the clinical considerations to take home with you when you're thinking of the use of Cangrelor in stroke interventions. First of all, we really want to minimize the duration of use. This is an expensive drug that has a lot of cost to it that has driven some hospital systems from adopting it. We want to make sure that we use it as conscientiously as possible, that we minimize the duration. To do that, again, stroke patients are not always able to swallow. Sometimes they're intubated. Sometimes they just have dysphagia related to their stroke. So we do really try to place an NG tube as soon as we're done with the procedure so that we can quickly do our transition and minimize the duration of use of Cangrelor, hence minimizing its cost as well. We also want to carefully choose the transition agent. The reocclusion cases that we saw in the Cangrelor arm both happened in patients in which the transition happens to clopidogrel, to Plavix. And as we learned from an earlier slide, that you cannot overlap Cangrelor with Plavix, and so you have a possibly 3-hour period of relative platelet reactivation when you choose Plavix. So our group has generally kind of moved away from the use of Plavix as our transition agent, especially when we're dealing with high-risk stents like intracranial stents. The other thing is that you want to use proper patient selection. For instance, if the indication for use is vascular thrombosis or in situ thrombosis, you probably do not want to use Cangrelor for those patients. Those are patients that are better treated with integralin. Now, in terms of future directions, where can we go forward with Cangrelor and neurointerventions? I think one important thing is to explore the safety and efficacy of using lower dose regimens. Some of the other centers that were mentioned earlier use smaller boluses and drips. Like Salahuddin et al. In 2021 published their experience of 12 patients with the use of half dose bolus and infusion, and seem to have good outcomes with that, as well as other centers as well. There has been some interesting adventures with the use of even smaller bolus, 5 microgram per kilogram, with groups like Entezami and Cagnasio. But in those patients, we see that they, in addition to the bolus, they use PRU-based titration afterwards to determine the infusion rate. Unfortunately, in their series and in similar series, there has been a high risk of reocclusion, one requiring re-thrombectomy. So these are things to take into consideration. Those are patients that really are in a critical period, and we do not want to risk such complications like preventable stent reocclusion. The other thing to keep in mind is cost analysis comparison. But when we do that, we should not just only take into consideration the cost of the medication itself, but also ICU length of stay, complication rate, outcomes, mortality. So there's a lot to be explored here, and I think that would require maybe bigger databases and data sets, as well as looking at overall hospital costs. In the cardiac literature, Jensen et al. Last year published a cost implication study in the use of Cangrelor that showed that in a hospital treating 1,000 PCIs every year, increasing the rate of using Cangrelor from 11% to 32% resulted in about 13% reduction in the cost of these interventions. The total cost was about $1.1 million, driven mostly by reduction in complications, reduction in the use of integralin, and less wait time for surgeries when Cangrelor was used as a bridging agent. So in conclusion here, I wanted to acknowledge the great work that Alex Devarajan did on this project with me. He recently presented this data in the national meeting of SNIS and is helping me write this paper out for publication as well. Want to thank the research team who's worked on this project in the past, as well as the pharmacy team that made it possible to use this medication system-wide. And I want to use our endovascular team for using this medication and promoting its safe use, as well as our neurocritical care team that really championed the ability to safely transition those patients in the ICU, and the stroke team as well. Thank you all, and I'm happy to take any questions.
Thanks a lot, Hazem, and thanks a lot for really championing this, because there have been numerous times where I've found it to be extremely helpful using this in the procedure, and then also, especially in the ICU, when we have to do an EVD on a patient who's on aspirin Plavix, transitioning onto Cangrelor, and then transitioning back after the procedure is done. So, I really thank you for that.
Thank you, Chris. Yeah, and certainly you highlight here an important patient population, patients with EVDs. It's much safer to envision the use of Cangrelor in these situations compared with things like aspirin.
Yeah, Dr. Shoirah. I'm sorry. Hey,
no, go ahead, Abhi.
This is Abhi. I had a quick question. Going back to your slide about integralin. I know our current protocol is, we wait 3 hours after 3 hours to stop it, stop the integralin after loading antiplatelets. So depending on the patients on either Plavix or Brilinta, would that would change or could be potentially increased to like 4 hours, because the half-life of Plavix is much longer. So the ablation was at like 75 Plavix. Would you wait even longer than you would for Brilinta? Or is there like a specific overlap that we look for in terms of transitioning from an oral to an
IV? That's a great question, Abhi. I think transition is one of those high vulnerability points in patient care in which, if the transition is not done in a careful manner, you risk having either excessive amount of antithrombotic effect or insufficient amount of platelet inhibition, both of which could have their own sets of complications. And I think what guides the management here in terms of the amount of time that you use for overlap between integralin and other agents is the time of onset of the other agent after load. With things like Plavix or clopidogrel, the time of onset after load is 4 to 6 hours, which is why when we are overlapping it with integralin, we wait for 4 hours. Whereas in medications like Brilinta, the time is 2 to 3 hours. With medications like Efient, it's only about 1 hour. So slight differences there in the time of onset that dictate the overlap time. I think you will find that most of us are a little bit more comfortable having a longer overlap than a shorter overlap. The risk of hemorrhagic complication is a little bit less than the risk of thrombotic complications if platelets are reactivated with a freshly placed stent. So in spite of these numbers, you will see that we always add maybe another 30 minutes to an hour of a safety margin.
Okay, thank you. That makes sense.
Hey, Hazem, that was a great talk. Just wanted to ask a question about the cost effectiveness. Like, I think it's important not only include the hospital costs, but the cost after the hospital. Meaning, if the patient's outcome is better, there should be a way to model, model cost savings over the lifetime. Maybe it's a good idea. I think there are people at the school that specialize in this sort of thing, cost effectiveness, and maybe it's a good idea to get someone like that involved to try to do like a long-term modeling.
I think that's definitely a wonderful suggestion, Joanna. Thank you very much. Certainly, cost effectiveness is not just the hospital costs. I think years of productivity lost, quality of life, mortality, those are all things that are, may not have an immediate cost impact on the bills, but have a huge impact on the patient and societal costs in general and healthcare costs in general. So thank you for suggesting reaching out to the research team in the school that specializes in that. I certainly will follow up with you on that. I think that would be a great addition.
Dan, do you have your hand up?
Yes. I was just wondering if you could talk about monitoring. So you talked about, after a certain amount of time, then transitioning to a different agent. Can you talk about the role of monitoring if a patient's going to get an EVD, for instance, getting a P2Y12 level, et cetera?
Yeah, that's a great question, Daniel. We in the early years of using Cangrelor at Sinai, we used to obtain PRUs after giving our Cangrelor load, as well as subsequent to that. Sometimes we have found that universally all patients come down, their PRU values, which is usually PRU values that reflect effective platelet inhibition, are usually in the 90 to 190 or 220 range. We found that in those patients, uniformly, they will be in the single digits. So their PRUs are extremely suppressed very, very quickly. We stopped monitoring because really there was no patients in which the PRU value would not come down to the single digit. What we have not been doing is repeating PRUs before performing procedures, just by knowledge of the pharmacokinetics of this medication and knowing that within an hour, it's effectively completely out of the patient's system. I think using PRU monitoring, if a surgical intervention is necessary before a 1 hour period has passed, is definitely a safe strategy to consider.
Do you know how long it takes to come back the lab?
Yeah, PRU is it is a point of care that we carry in our angio suite as well as in the cath lab. It's with Plavix, you have to collect your sample. With Plavix or Cangrelor, you have to collect your sample and process it within 30 minutes. You can process it immediately, but no longer than 30 minutes. And the result comes back within a couple of minutes. I have to say it has been finicky. The machine is not always working, and sometimes the quality maintenance of it is a little bit challenging. I think in the cath lab they have a lot more experience using it and frequency of using it, so it's a reliable place to do these tests. But we have definitely spent quite a bit of time with education and quality maintenance for the PRU machines, what we call the Verify Now machines, in our angio suites as well.
Okay.
Do we have any other questions? If not, thanks everyone for your attention, and we'll be back next week.